have to say, it's Dr. A's birthday today. It's Breast Cancer Awareness Month in October. And we have Jessica Ordonez, who is a genetic counselor at Myriad, to really educate us. This is a big day, and I think this is a birthday present to you because you are so passionate about this, and you actually do the MyRisk test from Myriad on every single patient. We're going to talk about genetics, MyRisk, genetic testing, gene mutations, everything cancer related. You know, one of the things that we get from a lot of our listeners and viewers is, how can I get the same kind of quality care as Dr. A gives her clients? And we say, don't go see Dr. A. That's why we started this podcast. We want to arm you with all the tools to be your own health advocate. And this test is one of those. Can you tell us a little bit about yourself? How did you end up at Myriad? What does a genetic counselor do? And then we're going to really dive into genetics and cancer risk.
Sure. So I'm a genetic counselor by training. So genetic counselors are master's trained, board certified professionals, and we have advanced training in human genetics as well as counseling. And in the beginning of my career, I worked in a clinical setting, as many of my colleagues do as well. So I worked seeing patients in oncology, general genetics, and I stayed in oncology for many years. And more recently, I transitioned to Myriad as a medical science liaison. So in my current role, what I do is partnering with providers, so with doctors, nurse practitioners who care for patients. And I often work as a bridge between the scientific knowledge that's out there, the guidelines, as well as the products that Myriad has available as a company. And my role is to stay on top of things, have meaningful conversations with people, so our products are used in a safe and effective way.
I mean, I've used it for 10 years. First of all, thank you for being on our podcast. I've used the MyRisk genetic test for almost 10 years in my practice. And what's shocking is, to this day, I get 99% of my patients who come to the office have not heard of a genetic test or have not done a genetic test. So I think it's a very important topic. Today, we're going to talk about all things genetics and your lifetime risk of breast cancer, and how, you know, people always ask me, why do you use MyRisk over other genetic tests? And it's the RiskScore part of it that I'm really interested and passionate about, and that's what we're going to talk about today.
Why is it important to get a genetic test? Because I didn't understand this. I think you said only 5% of all breast cancers have genetic markers. Is that correct?
Yes.
Is that correct?
So 5 to 10% of all breast cancer is hereditary. And I think there's an important distinction there. We typically say that all breast cancer is genetic, right?
Right.
But not all breast cancer is hereditary. And there's a difference there. If you think about it, about what cancer truly is, it's cells growing out of control. And most of the times that's triggered by a genetic change that can happen randomly. It can happen due to environmental exposures. But that doesn't mean that you were born with that. It's something that happens as we get older, right? So everything comes back to the genetic code in the end. But hereditary cancer really refers to that inherited genetic change that you were born with that makes you more susceptible to it. And that accounts for 5 to 10% of all cases.
And majority of patients don't know they have it. To this day, I have patients who come and they're like, well, I don't need mammograms because I don't have it in my family. And I don't need genetic testing. Sometimes I'm like, do you have family history of cancer? And they're like, no, thinking I'm talking about women cancers like breast, ovary, uterus. And I'm like, so no one has cancer in your family? Your dad, your uncles, your aunts, grandparents? And they're like, oh, yeah. My grandpa had pancreatic cancer. And then my dad had prostate cancer. Mm-hmm. All of that can affect you. For example, what I always say is pancreatic cancer can sit on a lot of gene mutations. Mm-hmm. So if you have one first-degree relative with pancreatic cancer, you better do genetic testing. Yes, it's not breast, it's not ovary, it's not uterus, but you still need to do that genetic test. So there's a lot of misinformation, and hopefully with this podcast, we can teach everyone what they need to know.
Because I think that's what I always hear from women. They say, I don't have the BRCA gene, so I'm fine. I don't, so can either one of you talk about that?
Sure. So BRCA1 and 2, they stand for breast cancer gene 1, breast cancer gene 2. They were the first genes that were identified to be associated with hereditary breast and ovarian cancer. And we've known about them the longest, but they're not the only genes. As science progressed, our methods became better. So we actually found so many other genes that are associated with breast as well as other types of cancers. And what's truly remarkable about hereditary susceptibility is that it's frequently not just the case that you have one mutation and you're at risk for one cancer, right? That's not the case. Usually, if you have one mutation, it means that you're often at risk for more than one type of cancer, right? So it could be in BRCA1 and 2, breast, ovarian, prostate, pancreatic cancer, melanoma. Those are all within the spectrum of BRCA1 and 2. And that's often the case. You're often at risk for more than one type of cancer. So yes, BRCA1 and 2 continue to be major players, but they are not the only players. That we've learned so much more over the years.
So please, I beg you, when we ask you if you've done genetic testing, don't answer by saying, I'm BRCA negative. I twitch every time someone says that. I'm like, BRCA is they're like 2 of the 48 cancer-causing genes. You know, I had a breast cancer patient from one of the biggest institutions in Los Angeles, comes to my office with history of breast cancer. They did a lumpectomy. She got radiation and chemo. Great. I don't think actually she didn't get chemo. She got radiation and lumpectomy. Comes to my office as a new patient. This is a few years ago. I'm like, did you do genetic testing? She's like, yes, I did. Office, I don't care who says what. I need to see it with my own eyes.
Yes.
So I persisted and I'm like, I need to see your genetic testing. She was kind of a little bit irritated with me. She went and got the genetic tests, brought it back, and I look at it and she was only tested for BRCA. This is like 5 years ago.
Oh, wow.
And I called her. I'm like, this is not enough. You need to take full panel testing.
Yes.
So I did the MyRisk test on her. It came back, I mean, you won't know this, as P10.
Oh, wow.
It's like a dynamite inside of you. It's associated with, this gene mutation is associated with so many cancers. So I called her and I'm like, you're at risk from kidney to uterus. I mean, the list goes on and on and on. And you need a double mastectomy because your lifetime risk of breast cancer is so high. She could not believe over the phone that this was happening. She's like, let me call my doctor because something's not right. So she went to her doctor and they're like, yeah, we missed it. So why am I saying this? Be your own advocate.
Yes,
I'm telling you today that we care about BRCA, but you don't have to have BRCA to be worried about your breast cancer. There's so many genes associated with breast cancer that can increase your lifetime risk, and you need to know about it. And sometimes you could have that gene with a family member who's only had prostate cancer,
Right.
or pancreatic, has nothing to do with breast. That's why it's so important to take this test and just know what's going on in your DNA.
Can I just say, I love what you said about having the report in front of you, right? Because so many people, sometimes when I was in clinical practice, that came up a lot. People were just not happy with us asking for that. But unless, your doctor, your medical team can actually see what you were tested for, then we don't know. We don't know if you were under-tested and if you need anything else based on your family history as well. So it's terribly important that you not only have that at hand, but share that information with your family members too.
I want you to answer a question because this is a common issue. There are a lot of genetic companies out there that run genetic tests. And the way I describe it to my patients is, it's like you drill into the ground and you have to see how deep you drill into that ground. You can do some superficial genetic tests, or you can dig deeper into that gene. And from what I understand, Myriad has the most data on variants. That, variants are when you don't have a gene mutation, but there's some findings in your DNA that could increase your risk. We just don't know enough about them. So they keep a log of it. And in a few years, if that specific gene mutation gets associated with certain cancers, then they notify you. Is that true?
Yeah.
And so tell us, how is Myriad different than other genetic companies? And when should patients retake the MyRisk test?
Yes, thank you for that question. So MyRisk, it really stands apart just the way that it approaches risk assessment. It approaches risk assessment comprehensively. So what I mean by that is, first, we're concerned with excluding that someone has a hereditary susceptibility. That's why we test for those 48 genes associated with 11 different types of cancers, but we do not stop there. In addition to that, we're looking at the patient's the patient's family history, and the test has a component that is called RiskScore, which actually calculates a 5-year as well as a lifetime risk for breast cancer for eligible patients. So one thing that sets us apart is the way that we approach the way that we approach cancer risk comprehensively. So that's one thing. And also what you mentioned about variants. So variants of unknown significance are genetic changes that we all have, right? Our DNA makes us different from each other, and having a difference is not in itself bad in any way, right? It's when that genetic change actually affects what the gene is supposed to be doing, that's when we're concerned about that could actually have an implication in someone's health. But so it's important to monitor the knowledge, monitor the literature, continue to gather data, analyze it in different ways to make sure that once you have enough data, you can actually call that variant clinically significant, right?
Right.
And it's important to be careful on how to do that, because people make life-changing decisions because of that information. They get preventive surgeries, their family members do as well. So you want to be really sure that when you're calling something positive, it truly is. And Myriad is extremely careful on how to do that. We monitor the literature, and we're very careful in doing that too.
I have so many stories I can share, you guys. I have a patient in my practice who I love and adore. She's older right now, but when she was younger, in her 40s, they do the genetic test, and they told her that she had BRCA1. So obviously at age, right as soon as she found out, she removed her ovaries before menopause. She went into surgical menopause. She removed her breast. Did a double mastectomy. And when she showed up to my office years later as a new patient, of course, I ask, I'm like, I need to see your genetic test. She's like, oh, it's been done so many years ago. I'm like, then can I repeat it again? Because I just have to have it in your chart that you're BRCA. Because for BRCA patients at risk for pancreatic cancer, at Cedars, we actually have a pancreatic cancer surveillance clinic that I send my patients to. Mm-hmm. So I really wanted to know. So I do a BRCA test. I do the full MyRisk test, and it comes back negative.
Oh,
no. I call Myriad. I'm like, no. This is a mistake. This patient is BRCA positive. You need to check it again. They check it again. They call me. They're like, no, this woman has no gene mutations. Mm-hmm. I called the patient. I'm like, I need to get the results from your doctor. So we start digging. It took like a few weeks to get her results. When I get it, guess what it was? The test was negative. She had a variant of BRCA, and they read it wrong. Mm. And this happened 2 months ago in my office from another patient. That's why it's so important. Grab that report yourself, and it's black and you either get a green sign that says negative, no gene mutation, or you get a red sign that's positive. If you get a red banner, that means you're positive. If it's green, you don't have it. So it's very important not to confuse gene mutations with this variance, number one.
Well, so can you explain very clearly the difference between the variant and the mutation?
The variants are variants of unknown clinical significance, which means that these are mutations that they picked up, but they have not been associated with cancers. They might in the future, but we just don't have enough data. So we keep, we hold on to it until we get more data on it. But the actual gene mutations are gene mutations. Does it make sense to you?
Yeah,
because if you understand it, everybody else understands
I understand it. You're right. So see, if I understand it, then everybody else can understand it. That's true.
As far as variants of unknown significance, I wanted to just add to that. That seems to resonate sometimes with people.
And that's very important because it is not uncommon for physicians to read that positive variant as a gene mutation. So that's, I had a patient a couple of months ago who came to my office for a second opinion for BRCA, and she was ready to remove her ovaries and remove her breasts. And when I got a copy of her genetic test, she was actually negative for the 48 cancer-causing genes, but she had a variant for BRCA, and her physician had read it as positive BRCA. So the reason I use the MyRisk test in my office, and I've used it for 10 years, is because of one specific step that MyRisk takes that other genetic companies don't provide. So when you get your Myriad report, number one, you get checked for 48 cancer-causing genes. 2 of those 48 are BRCA1 and BRCA2. So it doesn't end at BRCA. They check you for 48 cancer-causing genes. Number 2, on the report, if you scroll down, you'll see your Tyrer-Cuzick score. Tyrer-Cuzick is a tool we use to calculate a woman's lifetime risk of breast cancer and her risk of breast cancer over 10 years. So that's important. And Tyrer-Cuzick only goes by history and family history. So your height, your weight, density of your breast, what age you had your period, what age you had your first child, whether or not you've had children, are you Ashkenazi, have you been tested for BRCA? So you answer these questions, which we have on our podcast on SheMD, and it gives you a number. So that Tyrer-Cuzick percentage is right there on the report. But MyRisk takes it another step further, and they add the RiskScore. RiskScore is the combination of Tyrer-Cuzick, which is based on your history, plus small DNA markers. These are markers that some women carry in their genes. You don't know if you have it or not until you do the genetic test. And these are markers that individually they don't do anything, but some women have a ton of these gene markers on their DNA. So for these specific group of women, their Tyrer-Cuzick might be low, but if they have a lot of these gene mutations, their lifetime risk gets pushed up, and they report that as RiskScore on the Myriad report. So on the report, you get tested for the 48 cancer-causing genes. You get your Tyrer-Cuzick score, and then in addition to that, you also get your RiskScore. I had a patient whose lifetime risk of breast cancer on the Tyrer-Cuzick formula was 17%. But when I ran the MyRisk Myriad test, her RiskScore went all the way up to 37%. I want you to understand this. So she was 17% Tyrer-Cuzick, which puts her at an intermediate risk for breast cancer. And once they did the RiskScore on her, it went all the way to 37%. What does that tell you? That she didn't have any of these gene mutations, but she had tons of these tiny little DNA markers that pushed her lifetime risk all the way up.
And so what happened?
Well, because of that RiskScore, I sent her for MRI against everyone's advice. And she ended up having a biopsy, and she actually had breast cancer. So that's why I'm so passionate about MyRisk. I mean, I've done it for 10 years, but for me as a clinician, that RiskScore has a lot of value.
You know, and cancer risk is complex, right? So I frequently think about it as a balance scale, right? Like on one side, you have the risky side, the risk factors, and on the other side, you have the protective side, right? And on the risky side, you have different ways, and each way is going to drag that scale a little bit differently. So, and the genes are not the same. They don't contribute equally to your risk. So you have genes like BRCA1 or 2 that are going to weigh like a brick. They're going to really tip that scale towards the risk. But you have really small genetic variations that are common in the population, but that individually, they're not risky. They weigh maybe like a grain of salt, right? So having just 1 or 2 of those is not going to make a difference. But if you have like a bag of sand, that's also going to tip the scale towards the risk side. So MyRisk just kind of captures all of those levels of genetic variation too.
I mean, that's incredible.
Yeah.
So what do women do? Like right now, listening to this podcast, they're saying, I want to be informed.
So here's what you need to do. Number one, if you have family history of any cancers, honestly, I don't care. Just take the MyRisk test.
Right.
It's a life-changing test.
Yes. No, it's a life-saving test.
If you have family history of any cancers, if you have breast cancer, colon cancer, pancreatic cancer, ovarian cancer, uterine cancer, I mean, the list goes on and on and on. But if you go to your doctor and say, I need an order for this, then you can order the kit from Myriad, and they can even send it to your house. You can either do a blood test or sputum test at your doctor's office, or they can send a kit to your house.
Yeah.
You collect the sputum, you send it to Myriad. They run the genetic test, and they have genetic counselors available to basically talk to you about your results.
Right.
And insurance usually go by guidelines that are available, and there's different ways to look at family history, right? So if you think about what's important to ask in your family history, right? So first of all, both sides are important. I cannot really emphasize that enough.
Good point.
So ask about your mother's side, ask about your father's side. That's the first thing to know. Then, you can think about it as multiple cancers too. If you have a lot of different cancers on one side of the family, that should call attention for a conversation with your doctor about genetic testing. If you have rare cancers, Dr. Aliabadi, you mentioned different cancers like pancreatic, ovarian. Those are considered rare cancers, right? So anytime you have some of those in your family, that's a reason to be concerned. And if you have just people diagnosed at young ages, in genetics, we frequently use age 50 as a baseline to where we are concerned that there could be a hereditary link. So if you have a lot of people diagnosed in the 30s, in the 40s with different types of cancers, that's a reason to talk to your doctor.
Can I ask you a question? So I had a grandmother with breast cancer, but she got it in her 80s. Is that considered genetic?
It might be. So not all patients, let's take BRCA. Not all patients with BRCA will get breast cancer in their 40s or 50s. You can have, I've had patients in their 70s, they get breast cancer and they don't even have family history because they've had one sister and nobody else, and they don't know their family history. And these are
But one sister is hereditary.
It's not always. So here's what I'm trying to explain.
This is what I don't understand. This is what you need to explain this.
If you have a grandmother with breast cancer, even if she was older, it's less likely, but please do genetic testing. Take the test. Yes, if they're older, it makes it less likely, but it doesn't mean that there's zero chance.
Okay.
If it's your paternal side, please don't come and tell me it wasn't on your mother's side. If you have a paternal grandfather with prostate cancer, aggressive, you need to take genetic testing. If you've had an uncle with pancreatic cancer from your dad's side, mom's side, it doesn't matter. Take the test. It's a life-saving test.
Yeah.
I want to use another example. I should write a book about all my examples. This is a patient I saw this week. She has family history of breast cancer, not very significant. She came to me and she told me she's been tested for BRCA and it's negative. I said, listen, I want to do the full panel. I did the full panel with a Myriad, and she came back positive for CHEK2.
Yeah.
Can you explain what CHEK2 is to these beautiful people?
Sure. So CHEK2 is a gene that is associated with an increased risk for breast cancer.
Yes.
We also know it's associated with an increased risk for prostate cancer for men
and colon.
Colorectal. So it's interesting you bring that up because the guidelines have recently changed. So we believed that it was a gene associated with colorectal, but the evidence is kind of backing away from that association. So still much to learn about, but we do know for sure that it is associated with an increased risk for breast cancer.
And I think that risk is about 48% lifetime risk.
It can vary, but yes. It's definitely over 20%.
Wow, this is the point. This is the point.
But let me tell you about her. She actually was not happy with her breast. And last year, she went through a very big surgery for breast reduction with a huge recovery. And when I told her her lifetime risk was high, like I always do, I told her she had 3 options. Option number 1 was to do imaging every 6 months, alternating between mammogram and ultrasound and breast MRI. Option number 2 at a high lifetime risk was to take anti-estrogen medications to reduce that lifetime risk, but those meds have side effects. I'm on it right now: hot flashes, vaginal dryness, fatigue, hair loss, joint pain. The list goes on and on. So it's not an ideal medication for everyone. And the third option at a high lifetime risk could be a double mastectomy. You know what she told me? She was literally shaking in her chair. She said, I went through a big surgery last year. For her, she would have done a double mastectomy had she known that she had this gene mutation. because of her strong family history. So she was so upset. And I was like, you don't need to be upset. I'm glad we did this.
Yeah.
We figured it out. But, she was just so disappointed. And she kept saying she was disappointed at herself. And I was like, this is not your job. The healthcare system failed you.
Yeah.
You didn't fail yourself. You didn't know.
Yeah.
Do you know? And that's why it's so important.
Yeah.
It's so, I can't
Knowledge
emphasize
is power.
this
Yeah.
enough.
And family history sometimes it's just not a perfect proxy. It really isn't, because we live in a globalized world. Sometimes you lose touch with relatives. They live somewhere else. You don't know their family history full scope. Sometimes your family structure itself has limitations. There's not a lot of women in the family. So some of these genes affect women a lot more than men, right?
Mm-hmm.
Everybody has them, both men and women, but the risks are different. So that's going to make a difference in the way that you see a cancer history appear in a family, right? So it's important to look at family history critically.
And what else I do? I ask all my patients who are adopted to take the test.
Yeah.
I have to say, in my practice, I pretty much force them. I'm like, if you're adopted and you know nothing about your family history, take the genetic test. The other important thing I want people to know is you don't want to test someone at age 18 or 19. You don't want to traumatize them. I start genetic testing at 25 in my office because, especially in cases of BRCA1 and 2, you have to start imaging. You have to start reducing the risk of ovarian cancer. So you have to be more proactive, but definitely not before 25.
So Jessica, what would you say to a woman who's listening, who has taken MyRisk or another genetic test and it's come back super high lifetime risk, or the BRCA1, BRCA gene? Like, how do you counsel? Because with MyRisk, they can see a genetic counselor who walks them through. I just sort of want to give some advice to any woman listening who's now just faced with this.
Yeah. So this information is life-saving. What's worse is truly not know you have this. Walk all your life without knowing that you have an increased risk. If you, let's say, are BRCA1 positive, there are a lot of options for you. And I think that's the most important thing to know. You have options. This doesn't mean that you will get cancer. That's not the way hereditary risk works. We just have a better estimate, and we know what to look for, and we know what to do. Your doctors are going to know what to do and how to approach that risk, and you have options. Yeah. So this is not a death sentence in any way. This is truly just life-saving.
Right.
You guys, I had a patient from Europe. This was a few years ago. I diagnosed. She came here. She had strong family history. I did the genetic test. She tested positive for BRCA. I brought her back to my office because, I don't like to call them. I like to face them and reassure them and give them all the options. So I brought her back to my office and I said, you have BRCA and you have more than 80% lifetime chance of breast cancer, more than 40% of risk of ovarian cancer. You're at elevated risk for pancreatic cancer, melanoma. I went through all of it. She looked at me. She's like, you American doctors are crazy. And I'm like, why? She's like, you really think I'm going to remove my breasts and I'm going to remove my ovaries? Nothing will happen to me. You guys are crazy. I'm going to sit with my doctors and, back home. And, it's fine.
It's a choice.
That. It's a choice.
Yeah, you just have the information so you can make your own choices.
I did my job.
Yes. Yeah, we're not telling you what to do. That's not our job on this podcast. That's not even your job as a physician. It's to give the best information, educate them, and then all give them all the options. And that's really what you guys are doing. I think we're going to really educate women. I really understood this today. And if I understand it, everybody understands it.
Yeah, because you're not a doctor and you're not in the medical field.
So I think this birthday day of this woman, this is the perfect podcast because this is really one of her life goals.
I'm 5 years cancer-free.
Yay!
October.
Congratulations.
Amazing.
It's my 5-year anniversary for my cancer. It's Breast Cancer Awareness Month. It's my birthday. Honestly, I think I was born in October to just do all this.
Yeah. And can I add something too? It happens to be Hereditary Cancer Awareness Week.
Oh, there you go.
Yes. So definitely, yesterday was Previvor Day. It means that you have a mutation, but you haven't developed any cancer.
Wait, what is the word? Previvor?
Previvor.
Like pre-survivor?
Yes.
Previvor.
Previvor. So you have a mutation, but you have not developed a cancer associated with it. And this, these women and men who have a genetic mutation but haven't developed any cancer are often face very difficult decisions.
Yeah.
And they're so brave. And it's such an honor to participate in their care, or in my role in the physicians that care for these patients too. So
can I say one more story?
You can.
All right.
It's your podcast.
I just want to say one time, this was like maybe 4 years ago, I went to a party at night, and I think I've told you this story. And I don't drink, but I was at the bar getting my water, pretending like I'm drinking. So as I was waiting for my water, I heard this woman next to me talk to her friend, and she was saying how her dad was diagnosed with pancreatic cancer. And, I can't hold it when someone says that. I didn't even know who they were, but I tapped her on the shoulder. I'm like, I'm really, really sorry, but I'm a gynecologist and I overheard you. She looked at me, she's like, oh, I know who you are. I'm like, if you have family history of pancreatic cancer, you have to take the genetic test. And she's like, really? What genetic test is this? I'm like, I wrote it down on a napkin for her and I went home, and it all ended. A year later, I was at a different party, and this woman, same woman, I didn't remember her, but she walked up to me and she's like, I want to give you a hug. And I was like, do I know you? She's like, yes, remember like a year ago at the bar, you told me to go do genetic testing. Well, I took the test and I was BRCA positive. My dad was BRCA positive. You saved an entire generation of our family, because so many of my aunts and uncles ended up being diagnosed because of that one comment when I tapped her on the shoulder.
That's amazing.
And that's the power of genetic testing. Yeah. And that's probably one of my favorite stories ever. If you're listening to this, I'm so proud of you for listening and taking that test.
But we want to say this, just go get genetic testing. Education is power. And that's going to be your birthday present to Dr. A.
I know. The most important lesson we learned today is, if you have family history of ovarian, pancreatic, and breast cancer, especially as a woman, you have to take the test. Make sure besides Tyrer-Cuzick, you also know your RiskScore, which is Tyrer-Cuzick plus those little tiny DNA markers that can increase your lifetime risk of breast cancer. Once you do the genetic test, make sure you get a copy of it and you read it yourself. And if you don't understand it, ask for a genetic counselor.
Yeah. Amazing. Yeah.
Know your risk, know your red flags, talk to your doctor. That's all really good takeaways.
Yeah. This is going to save a lot of lives, I think. I hope for
your birthday. I know, for my birthday.
Happy birthday.
Thank you.
Thank you again for joining us today. Thanks so much for joining us today on SheMD.
If you want to own your own health, a good place to start is by following us on social media at SheMD Podcast, and by subscribing to our show on YouTube or wherever you get your podcasts.
For takeaways from today's episode, visit our website, shemdpodcast.com. We'll see you next time on SheMD. This podcast is for educational and entertainment purposes only. It is not intended as a substitute for a physician's medical advice. You should regularly consult your medical provider in matters relating to your own health. Even though we share our honest beliefs on SheMD, some of the products and services we discuss may involve sponsorships or paid advertising.